Thank you. Good afternoon. We are happy to present our work. I have nothing to disclose. The aim of our study was to describe the circadian rhythm of post-void residual and voided percentage in older women with urodynamic stress incontinence and/or detrusor overactivity. ICS defined voided percentage as a numeric evaluation of voiding efficiency. Our study was a single-center prospective observational study in a tertiary referral hospital. We had a convenient sample of female patients who were 65 years or older and who consulted for diagnostic workup of urinary incontinence. All the patients were hospitalized for a frequency volume chart during 24 hours, and we measured post-void residual after every void. These are our results. We had 90 patients with a median age of 76 years. As you can see, we didn't find any significant difference between mean post-void residual in all diagnoses, but also for maximum PVR, mean voided percentage, and minimum voided percentage. When we look to the circadian differences, we did not even find a difference in diurnal and nocturnal mean post-void residual and voided percentage in and between all diagnoses. And when you see the pictures, the left one, you can see there is no difference in diurnal and nocturnal maximum post-void residual in and between all diagnoses. But if you look to the minimum voided percentage, we found a lower diurnal voided percentage in all diagnoses, but no differences between diagnoses. And we measured why there was a difference in these minimum voided percentage, and we found that the differences was because of the differences in voided volumes, not because of differences in post-void residuals. So this is the first study where we provided evidence that there is no circadian variation of post-void residual or voided percentage except for minimum voided percentage. As I told you before, that the difference in minimum voided percentage was because of the voided volumes and not because of the post-void residuals. Our hypothesis is that it's because of convenience or premature voids during daytime, and we think that women have then a less effective detrusor contraction. Our study design could be criticized because we have a lack of a control group of healthy older women, or we only measured post-void residuals during 24 hours instead of 3 days. But as long as we don't have patient-friendly equipment to measure post-void residual at home, it's not cost-effectively to hospitalize patients for 3 days to measure this. So we think that future studies are needed to look for intra-individual variation. Our conclusion was that measurement of PVR should not be routinely required to differentiate between those diagnoses, and bladder emptying is more effective during nighttime than during daytime.
The floor is open for question.
Bill Gibson from Edmonton. Thanks very much for presenting a really interesting study. I have two related questions. Firstly, why did you think there might be a difference? What was the driver for doing the study? Secondly, clinical experience suggests that women with significant prolapse get nocturia at night. We say night, but get nocturia because when they lie flat, their prolapse reduces. Did your women have prolapses, or were they assessed?
We did assess prolapse, but we didn't calculate if there was a difference between them because our groups were too small to do statistics. And why did we measure post-void residual during nighttime? We hospitalize in our hospital older people who are not confident enough to make a good bladder diary at home. Then we hospitalize them during 24 hours, and we always measure post-void residual because we think in some patients there could be this overdistension of the bladder during nighttime, and we want to see if that is the case.
Thank you. Other question from the floor? I was wondering if you said you didn't consider prolapse. I was also wondering about medication. Were those patients on any medication that could have affected the voiding patterns during night?
After those 24 hours of where we collected data about their micturition. Then they had all an urodynamic investigation, so we stopped all medication that could be interference with their voiding pattern.
Okay, thank you. Another question?
Michael Wishaw, Melbourne. I think that's interesting data because I find on my ward we're always wanting to understand how well people are voiding, even just in a screening process. And we're usually doing that in the daytime, and quite often the voids are prompted rather than at the time of need. And we're often finding that they actually have higher residual than they might at other times. So it's just supportive of that. Thank you.
Okay.
So if there's no more question, we will move on. Thank you very much.